capsaicin cream, which is very helpful and is safe even for the elderly, and is effective in inhibiting substance P, which is one of the neurotransmitter mediating pain. So capsaicin is a good alternative for those patients. But if they're failing Tylenol should always be the first drug of choice for osteoarthritis, and you can recommend that the patients take it around the clock, unless they have a contraindication like liver failure, things like that. But you can tell the patients, just take one Tylenol every 4 to 6 hours. Before, we used to tell the students avoid more than 4,000 milligrams. Now more and more research is showing that chronic Tylenol use is a very common cause of hepatic failure. And I have at least 2 patients that they ended up with a liver transplant because of overuse of pain medication. And that's the reason why, before you guys entered in the health profession, we used to have a lot of the narcotics were combined with higher doses of Tylenol. We used to have something called Vicodin. Vicodin is almost gone. Now we have Norco, which has the same amount of hydrocodone but much less acetaminophen. And people can end up underestimating the amount of acetaminophen. So my advice to you is just to keep it below 2,000 milligrams in a 24-hour period. For those patients that are failing all the other things that I just mentioned, then tramadol is probably the next step. And remember, arthroscopic lavage is for end stage. So management, you need to always advise the patients to lose weight, refer them to health education for weight loss, or to a dietitian. And you need to try to minimize the exposure and then try to simplify their work duties. Physical therapy works for quads strengthening. Injections, you can always do them every 3 to 4 months. It's very easy to do. I want you guys, when you're doing rheumatology, to try to learn that skill, because it's going to be very useful for you in the future. It's very easy to do. I do it all the time. And it's just instant gratification for the patient. So you can just combine 1 cc of triamcinolone, which is Kenalog, with 1 cc of lidocaine, and that provides instant relief. Most of the relief comes in the first 24-48 hours. There's some randomized studies showing that these injections of these cartilage, hyalo, I don't even know how to pronounce that. So it's not superior to just injecting the corticosteroid. And those injections of this collagen and these substances is pretty expensive, and is not covered by most insurance plans. And at the end of the day, when they do the analysis, it's no different than just injecting triamcinolone. So, but I want you to know that that's an available treatment. You're gonna see it everywhere advertised as an alternative, because these patients, obviously, they're dealing with a chronic and very incapacitating condition, and they're desperate to get help. And they end up getting all sorts of things. And surgery only reserved for those patients when everything else has been exhausted. So we tell the patients, let's just keep going. If this becomes annoying, call me back. We'll do the surgery. But it's for end stage disease pretty much, because it's not forever. After a total joint replacement, you need another one after 15, 20 years. So if you have a younger person, imagine what are you gonna do? Replace the joint every 10 years? So this is a very useful picture. Review it before your board. So distal DIPs, you think about osteoarthritis with the classic Heberden nodules, or you think about psoriatic arthritis. Remember I told you guys? Psoriatic arthritis in the DIP. For the MCP, you think about the Bouchard nodes in osteoarthritis, or you can also see that in SLE or rheumatoid arthritis. And for the MCPs, you think about RA, lupus, and hemochromatosis. Have you guys ever seen hemochromatosis? So it's a genetic disease from a mutation. It's actually autosomal recessive. You need to have 2 copies of the gene to be able to develop the full mutation. And these patients have abnormal increased absorption and storage of iron. And the tests that you do for screening, you check a percentage of transferrin saturation or a ferritin level, and if it's pretty high in a patient with severe joint pains, then you have to think about, on your boards, they may present you this joint pains. They may present the patient with bronze diabetes. Have you heard about that term? So they may give you a patient who has diabetes, type 2 diabetes from occupation of the pancreas by iron deposits. So these patients develop heart failure as well, because they can have severe deposits, and they can develop liver failure especially for those that are drinking, and having hemochromatosis is just like it's lethal for the liver. They're going to end up getting a liver transplant. Okay? So think about a hemochromatosis when you see that kind of description. All right, go ahead, Cable.
A 62-year-old woman with 4-day history of swelling and pain in the left ankle. She has 6-year history of Crohn's associated with joint involvement of the knees and ankles. The last disease flare was 2 years ago. At that time, she was treated 3-month course, tapering prednisone and infliximab. She has continued taking infliximab. She also has been on azathioprine for 3 years. On physical exam, temperatures 100.5, pulse 88, respirations 18. Left ankle is warm, swollen, passive range of motion. This joint elicits pain. The knees are mildly tender palpation bilaterally, but don't have effusions, warmth, or erythema. Range of motion of the knees elicits crepitus bilaterally. The remainder of the musculoskeletal is normal. Arthrocentesis in the left ankle is performed and yields 3 mils of cloudy yellow fluid. The synovial fluid leukocyte count is 75,000, 90% neutrophils. Polarized light microscopy of the fluid shows no crystals. Gram stain is negative. Cultures are pending. What's the most likely diagnosis? Something septic.
Septic joint?
Just got it here. Just got a light count on the joint.
Warm, swollen.
It's not crystal articular. It's Crohn's.
Do we all agree?
Yeah.
Okay, very good. So this is something that you have to be very careful when you're working at the urgent care. Last Sunday, I did a shift at Pasadena Kaiser, and I got a guy who came in with severe joint shoulder pain, and he was seen the day before by another provider. At the time, his vital signs were normal. They did an x-ray. The x-ray didn't show any acute pathology. So he came to me, and I'm ready to discharge the guy, and I realized that his temperature is 100.9. He's like, oh, strange. So I went again, I talked to the guy, like, do you have any symptoms? Like, no sore throat, no runny nose, no pain, burning sensation, no cough, nothing. So I had the nurse check the temperature again, and it was 103, right in front of me, like evolving, right? And I tell the guy, you know, this is quite abnormal, and you have like severe pain in one joint, and I don't have an explanation because I don't know how to tap the shoulder. I can tap pretty comfortably the knee, but I don't know how to tap the shoulder. Or at least I don't recommend you guys do that, because if you work in an urgent care setting, I'm sure they have a ortho PA or an orthopedist on call to be able to do this kind of test. So to make a long story short, the guy refused to see ortho because I called the orthopedist and he told me that he needs to come into Sunset, just to Kaiser Sunset, just to get the diagnostic arthrocentesis. So the guy basically left home. I just was very clear on my note. I have to find out what the hell happened with that guy. But what I'm trying to say for you guys is that there's some indications that are very clear to do a diagnostic arthrocentesis. This is one of them. If you have a fever, if you have an unclear explanation why the patient is having it, you have to. Because if you let that patient go, he can either die from sepsis or he can get permanent joint damage, because these patients, this is an orthopedic emergency. They need to get a joint washout. And unless they do that, they will get septic, or they will get permanent disability from destruction of the joint. So I have a little table that's going to guide you through like the number of WBCs and the findings, the more important findings, so you guys can make decisions. Okay?
In school, they were saying if the joint is hot and swollen and angry, like don't tap it because you might introduce more bacteria into it. So
I think whoever told you that is not right. If you have an acute synovitis that you don't know why, you have to tap it, because you're going to be looking either for crystals, if it's gout, or pseudogout, or septic, right? Like you look for gonococcal, you look for, you do a gram stain, you do a culture, and you do crystal analysis. So that's actually clear-cut indication to do a joint. You don't want to just like, oh, let me just inject you and give you some prednisone there. Like, how are you going to give prednisone to somebody with potentially a septic joint? That's malpractice. All right, who's next?
An 82-year-old woman with a 2-year history of osteoarthritis in the knees is evaluated for persistent swelling and pain in the right knee of 3 months duration. She now uses a cane for ambulation and is unable to go to the grocery shopping. Medications are naproxen and hydrocodone acetaminophen as needed. On physical examination, vital signs are normal. The right knee has a large effusion and a valgus deformity. There's decreased flexion of the right knee, secondary to pain and stiffness, and she is unable to fully extend this joint. Range of motion of both knees elicits coarse crepitus. Laboratory studies reveal serum creatinine level of 1.1 and a serum uric acid level of 8.2. Radiograph of the right knee reveals a large effusion and changes consistent with end-stage osteoarthritis. Aspiration of the right knee is performed. Synovial fluid leukocyte count is 3,200. Polarized light microscopy of the fluid demonstrates rhomboid-shaped, weakly, positively birefringent crystals. Results of gram staining cultures are pending. Which of the following is the most likely diagnosis? I think it's the calcium pyrophosphate.
Yeah. Very good. Like CPPD, I think calcium pyrophosphate deposition. This is CPDD. CPDDD. That's like always. That's how the rheumatologists refer to it. So always memorize this rhomboid shape, weakly positive birefringent crystals. That's the magic word, the $5 word that you need to know to answer it. If they tell you needle shaped or negatively birefringent crystals, that's gout. So that's why I call it pseudo gout, because patients can present like with resemblance of the gout syndrome, but it's a very different physiopathology. It's just like calcium pyrophosphate crystals, and usually it happens in elderly people mostly. So they don't have like a lot of other features explaining this disease, but it's not uncommon actually. You see this.
Do you know if the timelines differ between the pseudo gout and gout? Like, will one get better will gout get better with time as long as they're if they're on diet with dietary things that inflame it?
Yeah,
this went on for 3 months.
Yeah, this one is more like insidious. Like whereas gout, people typically they tell you, I went to sleep fine and I woke up like with this.
Okay.
This is classic. When you ask a patient like, so you went to sleep last night fine and then you woke up with this, and he looks pretty angry, red, that's gout until proven otherwise. If you see a patient like that in the urgent care, make sure you check labs, because patients with like unrecognized kidney disease, that may be a manifestation. They're just having gout and out of the blue. So if you don't have labs, recent labs, make sure you do at least a Chem7 and a uric acid just to confirm or rule it out. Ideally, you should send the fluid, synovial fluid, for crystal analysis, and that's usually available within an hour. Like the hard thing is to get the fluid, to get the tap. So, but you can always call like a PA, ortho PA, or like the orthopedist to help you with that.
But if you're like 99% sure it's a gout, would you still tab it just to confirm? Or
If you have an established diagnosis of gout and the symptoms are pretty classic, you don't need to tap them. You can just document symptoms reminiscent of previous gout flares or whatever. Yeah, but the key thing is, if you don't have a diagnosis and the joint looks angry, you have to. Otherwise, you can get in trouble. If you send the patient out, just take this prednisone or take these colchicine. What if the patient has a septic joint? So look at the vital signs, use your clinical judgment, but if you don't have a diagnosis, you're not going to be protected by the law. You gotta be wise about making decisions. I know it's kind of inconvenient, but it is what it is. So like I was describing, so basically for septic arthritis, many, like probably like over 50,000, and you cannot have like a positive gram stain. For the other arthritis, we have the traumatic and the osteoarthritis and lupus. You may have like a little bit, but nothing really impressive. Whereas the rheumatoid arthritis, more inflammation, and they can have up to 50,000. Gout looks pretty angry, can give you a lot of PMNs and strongly birefringent negative crystals, needle shaped. And pseudo gout, you guys already know the magic word. All right, Cable, or no, it's actually Johnny, right?
Yeah.
Okay.
A 20-year-old woman is evaluated in the emergency department for 1-day history of nausea, vomiting, and blood per rectum.
You can actually put it in red so we can keep it simple. So I'm giving you criteria for what disease? For lupus, right? So you're gonna be like, this woman has arthralgias, pleuritic chest pain, abdominal pain. She has the erythematous rash over the cheeks, and she has a friction rub. If you take a look at the labs, significant things here is that the creatinine is not normal. And you see that the complement is decreased. She has a very positive ANA titer and a very active urine sediment. Remember, that's how we were talking about yesterday. We have the time to talk about nephrology cases. This is a very active urine sediment. Having RBC casts, if you see RBC casts, is never normal. That's pathognomonic from glomerular hematuria. You know, remember, hematuria can occur from any part of the GU tract. However, if they mention RBC casts or acanthocytes like the Mickey Mouse cell, basically the RBC is filtered by the glomeruli and it's deformed by the GN, and then you can see like these little blebs. It looks like a Mickey Mouse. So that's called an acanthocyte. A red blood cell acanthocyte is pathognomonic of glomerular hematuria. So this patient, when you look at this, you have all these inflammation, like look at the ESR, haptoglobin is low, so this patient is probably hemolyzing. Look at the LDH. And the double-stranded DNA is positive. That's very specific for renal involvement. And you have a Coombs that's positive, so this person is hemolyzing. So basically the diagnosis is very clear to all of us. She probably has lupus, multi-organ involvement. Remember to review the MD SOAP. What's the name of the MD SOAP brain? How do you guys?
What is it called?
The mnemonic to memorize lupus.
Rash or pain? We have different ones.
Which one do you use?
Rash or pain. I think RASH or PAIN.
What do you guys use in the PA school?
I don't have one.
Okay.
It was something weird. It didn't have to do with.
Yeah, it's MD SOAP brain. That's the one I learned when I was in med school.
I've heard of that one.
Yeah, so basically make sure you review it. There are like 11 criteria for the American College of Rheumatology. You need to have 4 out of 11. Lupus is a nasty disease. Before they came up with effective treatments with cyclophosphamide and mycophenolate, patients were actually having a limited life expectancy. And most of the times they were dying as a consequence of like the treatments. Rheumatologists were giving like high dose steroids and patients were dying from opportunistic infections and all sorts of different things. But this is the 4 or more. Just I broke it down here into mucocutaneous criteria. So here I forgot to involve like also genital, ask for oral or genital ulcers. And organ system, you can have arthritis, which once again, I already told you is non-erosive, okay? The serositis, patients can have like pleuritic chest pain or pericarditis. Renal, bad disease like this, the renal and the brain actually has carries the most morbidity and mortality from lupus. So you need to act promptly on these patients, and once you treat them and the disease goes in remission, they do pretty well, but you have to recognize these patients early in the course of the disease. Otherwise, they're going to become dialysis dependent 100% of the times. If there is involvement and you don't treat it, 100% of the times you're going to be dialysis dependent. So, and there's a lab or immunologic abnormalities, including the anti-double-stranded DNA, the anti-Smith antibody, which is highly specific for lupus. And remember, you can have anti-phospholipid antibody syndrome that is associated with lupus, or you can have just the anti-phospholipid antibody syndrome that is not associated with lupus. On your boards, they may present you with a lady with multiple infertility, unsuccessful pregnancies, and they can give you these patients can actually bleed, or they can clot, or they may give you like a DVT or a PE, things like that. So think about lupus until you demonstrate that the patient doesn't have lupus. And the ANA is an excellent screening test because most patients, I would say 98% of the patients are ANA positive, but don't ever forget that you can have ANA negative lupus. It's rare. I'm yet to see a case, but it's in all the textbooks. You can have an ANA negative, but ANA continues to be the test of choice. And it can be false positive in many settings. You probably know that. But it's now that we have the anti-Smith and anti-iron P, we can pretty confidently call it lupus because of these two antibodies. For your boards, they may give you like Sjogren's syndrome. They do an anti-SSA and anti-SSB. And these are probably what you were doing, Johnny. You were studying these antibodies and it's very confusing. So make sure you review that. Like I always tell the students, like there's some things that you know that you're gonna forget. Just do like a page review the day before the test. For the test, one of the questions that they love to ask is anti-histamine antibody. We talked about it yesterday, remember? For drug-induced lupus related to hydralazine. In my career, I've diagnosed 3 drug-induced lupus from hydralazine, so they love to ask that question. Okay. So for disease activity, when I see my patients with an established diagnosis of lupus, I usually check the complement levels. Complement consumption is a sign of disease activity, and double-stranded DNA high titer is a sign of renal involvement. That's why I order these 2 tests when I see them. Okay, so let's try to move forward with this one. Let me see. So she has SLE, and labs are pretty abnormal. Okay, and I'm giving you a patient with really, really bad lupus with, if you read the word schistocytes, what do you think of? Hemolysis. So, and what else do you think of? Schistocytes, you think about TTP, thrombotic thrombocytopenia. Or you think about HUS, hemolytic uremic syndrome, and you think about like basically doing plasmapheresis in this patient. So, because even if you give them high-dose steroids or cytotoxic agents, you need to be able to remove those pathogenic antibodies. Otherwise, the patients can actually have catastrophic microangiopathy. Like patients with this, they can actually end up losing limbs or dying from like massive clotting in the heart or in the brain. So this is a hard question, but it's just for you guys to recognize that lupus can actually turn very ugly. And if a patient is having like severe like emboli phenomenon, like a thrombotic microangiopathy, you need to anticoagulate those patients. Otherwise, they can die. So this is a clear indication for anticoagulation.
This is the antiphospholipid?
Antiphospholipid antibody syndrome, yeah. That's pretty bad. I've never seen it this severe, but the other day they called me to participate in a case of a patient who they did a CT with contrast of the abdomen, and one of the kidneys was completely gone from a renal infarct, and she turned out to have like this thing, and she had no idea she had that. She just presented with abdominal pain, and from antiphospholipid. Like the workup came like a week after I released her from the hospital, came back like, holy moly, this lady has it. So she's on lifelong Coumadin for now. Okay, so it's the antibodies plus venous or arterial thrombosis, fetal loss or thrombocytopenia, and if you have neurological or renal manifestations, you need to basically, it's very important to determine that, because you either anticoagulate versus you immunosuppress. That's why they love to ask that question on the boards, because establishing the diagnosis changes management quickly. You need to anticoagulate these patients when they're having renal or brain involvement. Okay? Alright, I'll let you guys read this one because it's different. Who's next? I'm gonna get some water. So what does the patient have?
Sherman's?
Mm-hmm. What is the treatment for that?
Usually just
Plaquenil for Sjogren's. It's very effective, actually. So, if they're flaring a lot, you do steroids, but you try to do steroid-sparing options, either with Cellcept, Imuran, or cyclophosphamide. This person has actually, this is not Sjogren's, this is occasional swelling. Okay, so this person has a positive ANA.
Is that a false positive?
It's a false positive ANA, yeah.
With the SSA and N2O?
Yeah, and the rheumatoid factor is positive, yeah. So it's Sjogren's. So, do you guys know what the treatment of lupus nephritis is? Cytoxin. You're going to be using Cytoxin too in some pulmonary diseases like pulmonary renal syndromes. Have you heard about those? Cyclophosphamide.
Oh, it's
Yeah, it's a cytotoxic medicine. It's a chemotherapy like once a month. You're going to be using it if you're going to pulmonary. And the other option that is FDA approved is Cellcept. Cellcept is very effective. The nice thing about Cellcept is that it doesn't cause infertility. It's teratogenic, so you cannot use it in pregnancy, but if I have a young female and I have an option of treating her with Cytoxan versus Cellcept, I'm sure you're going to want to give her Cellcept because they did non-inferiority trials on these two medications, and they were able to demonstrate that Cellcept is non-inferior and it's pretty effective. Cellcept, mycophenolate. It's an anti-metabolite. It just participates in the inhibiting the folic acid pathway on the cells, basically on the leukocytes, the neutrophils. So it's very effective, like suppressing the immune system, but it has like side effects. You guys know the most common side effect? No, actually, Cellcept can give you like overwhelming sepsis. So Cellcept, you're going to see it a lot on your transplant patients. But the difference is the transplant patients, they get a little bit, like 500 milligrams twice a day. For patients on lupus treatment, they take 1,500 milligrams twice a day. They take 3,000 milligrams a day. So it's a lot. And it's very effective, but you gotta always educate the patients about, like, you got a fever, you need to go to the ER right away. And if you're seeing a patient in the urgent care with fever that is taking Cellcept or Imuran or any of these immunosuppressive medications and you don't have it clear, I recommend that you guys admit that patient or just bring him in for observation because something is going to show. Either a UTI or pneumonia or something else. Okay, so say this person, let's see the antibody assay. INA titer is pretty positive. Chest X-ray blunting of the costophrenic angles. 10 years Raynaud's phenomenon. Okay, so this person has muscle strain. No, this person has actually myositis, some sort of like ulcerations in the fingers. And a lot of inflammation, like muscle enzymes are positive. I think you guys have a patient with a positive CPK, right?
Yeah.
What ended up happening with that lady?
I think it's like going up to like 2,000 most recently.
Why is she?
You don't remember that?
They sent all the workup.
Yeah.
Okay. No medications?
No.
No over-the-counter meds?
No.
Remember we talked about clarithromycin and simvastatin and all that stuff?
No.
No recent exposures? Any heat stroke or any aggressive exercising?
No.
Nothing? This is a mystery, huh?
Still not sure.
Okay. So how do you diagnose this condition, guys? Yeah. For which antibody? Which antibody do you send? This is good for Johnny, so she can have nightmares the day before the test. SSA? Remember that's for Sjogren's, right?
I don't remember SSA. I remember
Rho and La is, Rho is the same as SSA, La is the same as SSB. Yeah, it's for Sjogren's disease.
And topo is for crest, right? Scleroderma?
Mm-hmm.
None of those.
I'm not going to torture you anymore. So anti-ribonucleoprotein. So this is a field in nephrology that is very abstract, and to be honest with you, that's the reason why I never liked rheumatology, because you have to really believe like what you're reading, but there's no, like, nephrology is very tangible. Nephrology, my interventions are pretty, I can measure them. Like when I give a medicine, I can see what the effect on the electrolytes is. Rheumatology is very abstract. There's a lot of like basic science research and a lot of like theoretical background in these interventions that they do, but in clinically speaking, I don't like it, because a lot of the times I have a good friend, she's a rheumatologist, and she tells me that her career satisfaction is not as good because yet she went into this field to help people suffering from this, and all she hears the whole day is pain. And a lot of the time she gets stuck treating patients that don't have rheumatologic diseases, but they end up under her care because the primary doctor doesn't know what else to do for them, and they probably have fibromyalgia, or they have some sort of like, you know, like I don't know, like psychosomatic pain, and she ends up like dealing with all of these patients. But when it comes down to connective tissue disease, there's a very gray area called the mixed connective tissue disease. So if you get a question, the patient has like a little bit of scleroderma, a little bit of muscle involvement. So it's like a lupus-like disease, but with myositis. And these patients actually, the test of choice is the anti-RMP positive. So fortunately, we don't have a lot of patients with this mixed connective tissue disease. Unfortunately, you're not going to be the one treating them. Rheumatology is going to be the one. But for the boards, like I was telling you guys yesterday, pheochromocytoma is very rare. Yet they love to ask you questions on the boards, which I think is useless because you're not going to see a case in your life. But I cannot tell you. I can probably say the same thing about mixed connective tissue disease. So just memorize, Johnny, anti-RMP positive, okay? Whereas Sjogren's disease is basically, these patients have like lymphocytic infiltrate destroying the salivary glands. They have like serostomy, they have like very dry eyes, very dry nose, very dry mouth, and they test positive for anti-SSA and anti-SSB. So if you have a pregnant woman with both abnormalities, the fetus, it needs to get an EKG, like they can do an EKG in utero, or they can do an echocardiogram, because these kids can actually be born with congenital heart block. I don't know if they're going to ask you that question, probably it's more like for internal medicine, but I want you guys to remember that like congenital heart block is seen in patients with Sjogren's disease. And these patients with Sjogren's disease, they have like an incredible increased risk of developing lymphoma, which is, like I explained to you guys early, it's like a sister disease for rheumatoid arthritis. Okay, so let's summarize this one. So this person has fatigue and some GERD with Raynaud's. Every time you see Raynaud's, you start thinking about lupus or mixed connective tissue disease. This person has ulcers in the fingertips. See cardiac, the patient has pulmonary hypertension findings like loud S2 with fixed splitting. That's when you see that, just think about pulmonary hypertension. And the patient has sclerodactyly. Where do you see sclerodactyly? Pitting scars visible over several fingertips. There's no peripheral edema. Okay, and then this person has like a restrictive lung disease pattern with decreased DLCO. Which one is the more likely diagnosis? Interstitial lung disease? Yeah. Pulmonary arterial hypertension. So remember, this is the magic word for pulmonary arterial. Loud pulmonary component of S2 with fixed splitting. Interstitial lung disease is more like a radiographic diagnosis. You can get obviously pulmonary function testing to describe it, but this is not consistent with obstruction. And
less than 0.8?
Yeah.
Or restrictive?
More restrictive, right? Yeah, but they're trying to give you like a patient with with pulmonary involvement, which is commonly seen in which disease, which rheumatologic disease? It's diffused scleroderma. So these things, the only thing I want you to remember for your boards, I put it in red. So if you have a patient with a scleroderma renal crisis, you treat with an ACE inhibitor, even in pregnant women or even if they're going into acute renal failure. So this is a board favorite. If you have a patient with all the features and going into renal failure, hypertension, ACE inhibitor is the drug of choice. And then there is an entity called watermelon stomach. Have you heard about that? So let's Google a picture so you guys can see it. You'll never forget it. Search the web for watermelon stomach picture.
Oh, wow.
So they show you a picture like this on your boards. Right. It's actually it's gastric antral vascular ectasia. It's scleroderma until proven otherwise. So just memorize those two things, because on your boards, I don't think they're going to be asking you about like all these overlapping conditions, because it gets very complicated. Like you can have limited scleroderma or diffuse scleroderma, and all these conditions can overlap. Like Cable was mentioning, they love to ask questions about the CREST syndrome. So just remember that CREST syndrome, they have calcinosis, Raynaud's, lower esophageal dysfunction, sclerodectoly, and telangiectasias. So, but two things that are probably more important to know is like if they show you a picture with watermelon stomach, or if they give you a scleroderma renal crisis patient, you need to treat them with an ACE inhibitor. Okay, I'm gonna go quickly on these ones because I don't think you're gonna get a lot of questions on Wegeners but I want you to know that they are part of the category of a small vessel vasculitis. Let me just this is patients with vasculitis. They can get renal artery stenosis. Okay, so this is what I'm gonna just mention briefly. So on this book chapter is like a whole book in the rheumatology. So important things that you need to know is that you can either have a small vessel vasculitis. When you have a small vessel, you think about ANCA positive and ANCA negative. So the ANCA is a test that is rarely available. It takes like a couple of days to come back. When you have a ANCA positive, you can either have microscopic polyangiitis. You can have Wegeners. We don't call it Wegeners anymore. We call it granulomatosis with polyangiitis. We call it GPA. And I think it's the same reason that Church-Strauss, that those two guys were Nazis or something like that. I don't even know what the story is behind. I think we're moving away from naming the disease after a doctor. They're just doing more like physiopathology descriptive names. We're going into that new era. Or you can get like a drug-induced, some medications can be associated with ANCA vasculitis. But if the ANCA is negative, you can either have a leukocytoclastic vasculitis. You see this in cryoglobulinemia and hepatitis C. Or a Henoch-Schulin purpura, lupus, or drugs when you see like an ANCA negative. But when you have a medium vessel vasculitis, on your boards, they're going to be asking you about, they're going to be giving you a picture of a renal angiogram, and you're going to see a lot of microaneurysms. When you see that, you think about polyarteritis nodosum. And which disease is associated with PAN? Hepatitis B. So, and that's like almost in every board that I remember taking, they always wanted to test your knowledge about like a medium vessel vasculitis, PAN induced by hepatitis B. Okay? The diagnosis is with the renal angiogram. You don't biopsy these patients. If you biopsy and you're so unlucky that you end up hitting one of those aneurysms, the patients can bleed to death. So if they tell you what is the next step in the management, the correct answer is renal angiogram, renal angiography. And Kawasaki, you guys see this in pits, right? Or yeah, I've never seen one, but you know, usually they have like, they look sick, they have a high fever. I think they have.
I did a workup for one, but it ended up being negative.
End up negative, right?
Yeah.
But they have like the tongue can look.
Yeah, the cheilitis.
Cheilitis.
Yeah, and then they have like red eye, like conjunctivitis.
Mm-hmm.
It all on boards. It's always a fever, a child with a fever for more than 5 days.
And you do not want to miss that because it's a disaster. These patients, they need.
The only time they get
Yeah, they get like coronary aneurysms and they actually rupture and they can die from this. Yeah, so And on the large vessel vasculitis category, important things that you need to know is that if you have a patient with giant cell arteritis, they can actually present with visual changes related to involvement of the ophthalmic artery. And these patients can actually present with temporal arteritis. So the diagnosis is with temporal artery biopsy. Who does that biopsy? ENT. Yeah, head and neck. So if you need to call someone, like his head and neck. But you don't wait for the biopsy results. If you suspect it, you start treating it right away. So when I get a patient like this and I suspect, I just call the ophthalmologist and I tell him, like, you need to come see this patient because he has like very abnormal findings and we're not qualified to do a good fundoscopic exam. And at that point, it's like kind of like a liability kind of thing. Like when you're in the urgent care and you're by yourself and somebody comes with like, oh, I can't see, what are you going to tell them? Call the ophthalmologist, right? It's just like, there's nothing you can do at that point. They hate to come, but it is what it is. You know, if the patient comes with acute changes in visual acuity, I don't care. It's 3 a.m., you need to come. That's what you get paid for, right? And Takayasu arthritis, you know, I've never seen one, but it's just like, they can give you like aneurysms, right? Like, I think like thoracic aneurysm. So it's just, you classify them by vessel size. If you remember that there's small vessels, and the small vessel is ANCA positive or ANCA negative. Medium vessel, PAN or Kawasaki, and then large vessels, we have the giant cell arteritis, we have the PMR, and PMR, which patient uses PMR? What's the clinical presentation?
Is that old lady?
Right, what else?
Hip and shoulder pain.
They have like proximal muscle pain, severe. And they can actually be limited because they can even have like wake up, like stand up because they have a lot of pain. And these patients, how do you manage them? And do they get better right away or it takes some time? No, it takes really fast. It's actually really fast. When you give steroids, they feel so much better the next day. Yeah. And then what is the test if you're in the urgent care and you're suspecting it? ESR CRP. Simple. And you will see this. I've seen it in the urgent care several times. It's not one thing that you're going to be concerned about, like other like life-threatening things, but patients they're very acute and they're very incapacitated. Okay, so this gets even more complicated. I think we're going to skip this so we can concentrate on some clinical cases. But this presentation you're going to get, like I told Ramiro to send it to you, to email it to you guys. But important things to know is that we don't call them Wegeners anymore, and we don't call it Church-Strauss anymore. I deal a lot with this because they are responsible for RPGNs. Have you guys heard about RPGNs? Rapidly progressive glomerulonephritis. So briefly, just to introduce you to that concept, like Dr. Ben-Zur, he never wants to miss a left anterior descending lesion or like a stenosis. Why? Because patients can die from it. As a nephrologist, I don't want to miss an RPGN, a rapidly progressive glomerulonephritis. So it's just a syndrome when the patients actually, they see you today, they have a little bit of nephritic urine sediment. Remember I showed you the WBCs, the RBCs, and a little bit of like proteinuria. The next time I see them in 3 months, they're already on dialysis. So as a nephrologist, it's very important that I take a look at every patient urine and I rule out an RPGN. And that's the reason why I always tell students and residents, like, I'm sure you're not going to go present an cardiology case without an EKG. And you guys do this all the time to a nephrologist. You present a case without a UA. And that's where the money is for me. I look at the urine very carefully. If I have a patient with unexplained rise in the creatinine and some concerning findings like WBCs, RBCs, I need to rule that out. And when I say RPGN, it's just a syndrome. It's like if I'm telling you, oh, you have a fever. Fever from what? Fever from a virus, from a bacteria, from a fungus, from a drug-induced fever, or what is this for? So the same thing, RPGN, we have very specific entities that have been associated with them. I'm just going to mention some of them so you guys get familiar. So we have the Lupus is one of them. Lupus can give you a type 4 lupus is also known as diffuse proliferative glomerulonephritis. This patient can have a crescentic form of glomerulonephritis. If I don't see them very closely, they're going to come back dialysis dependent. We have syndromes that are associated with the lungs and the kidneys that you're going to be seeing a lot. One of them is called good pastures syndrome. So good pastures is like lung and kidneys. When it's just limited to the kidneys, we call that an anti-GBM glomerulonephritis. And there's a test called anti-GBM. And if you get a question on the boards, on your boards, it's the treatment for those patients is? Plasmapheresis, plasma exchange. So don't forget that, because if you have a patient with that, you're gonna need a plasma exchange. Okay. So, and then we also have ANCA, associated vasculitis with severe crescentic disease. And lastly, we have patients with an entity called IgA nephropathy. IgA nephropathy is the most common GN in the world, and most patients have a very indolent disease that goes unrecognized unless somebody does a biopsy. And the most common thing is that patients have a little bit of blood in the urine, but a very small subset of these patients can actually present with a very angry, active inflammation of the kidneys, and they can go into full-blown renal failure unless you treat them very, very quickly. So that's what we call RPGN. It's like, you don't want to miss that as a nephrologist. Or like, I don't know, like dermatology has any emergencies? They do. They have like Steven Johnson's, and they have like purulent psoriasis. Those patients can actually, they need to be treated like a burn victim. Yeah. Or like a severe pemphigus. Yeah. But for me, like, that's most of this care. There's two things that can get you in trouble as a nephrologist. One is management of sodium cases, and like negligence from sodium cases is just really bad. People can die from it. Or missing out on RPGN. Okay? But I'll leave this thing for your review. It's just, I don't think it's going to be on your boards, but it's useful to have that. So medium vessel and large vessels, we talk about it. For the boards, for PAN, Hep C, Hep B association, and the diagnosis is with a renal angiogram. And these patients can have abdominal pain from mesenteric ischemia. Okay? I did this for internal medicine. It's like, you don't have to know